Last month, the co-chair of Ontario's COVID-19 Science Advisory Table, Steny Brown, put it bluntly when he said that, quote, COVID is an airborne disease. I think that's clear. But that hasn't always been clear. So here to help explain, in the nation's capital, we're joined by Dr. Sarah Adelman. She's an Ottawa-based physician and assistant professor of emergency medicine at the University of Ottawa. Dr. Adelman, it's good to have you on our program. How are you doing tonight?
I'm good, thank you.
Great to have you here. In terms of the key ways that this virus is transmitted, how is an aerosol different from a droplet? Because we've heard a lot more about the latter than the former.
Right. So an aerosol is a very light particle that will remain suspended in the air. And the time of suspension and the duration of travel in the air really depends on factors such as airflow and ventilation. So this is opposed to a droplet, which is a much heavier particle, which is emitted from the respiratory tract and which will fall to the ground close to the source. And it follows a more ballistic pathway, if you will. So to infect someone, it has to land in their mouth, nose, or eyes. And as I mentioned, it's not going to stay suspended in the air for very long. It's really, when we think about our 2-meter rule, this is based on the idea of droplet transmission and a droplet falling close to the source.
We've heard the National Medical Officer of Health, Theresa Tam, use the analogy of Omicron traveling through the air as something similar to secondhand smoke. Is that a good analogy to use?
Yeah, so I love that analogy, and I'd say that aerosols are like secondhand smoke. And I think this is really easy for us to conceptualize. And Dr. Tam, in fact, did use this analogy a couple of months ago, although it was first, I think, developed by the aerosol scientist, Dr. Lindsay Marr. So if you think about aerosols as a plume of smoke that are, again, emitted by a person, you can imagine how they can linger in the air. You can imagine sort of seeing the smoke travel, that traveling is going to depend on factors such as airflow. And you can also imagine then that in a poorly ventilated space, the aerosols are going to stay lingering in the air much longer. So similar to smoke. And that really drives home sort of the importance of ventilation. You can imagine that when you open a window and you dilute the air, you're going to have a decrease in the amount of smoke that's in the air.
Well, let me pick up on ventilation. Is it also possible then that if you have aerosol in one room, a ventilation system could take it into another room and you could catch Omicron that way?
So this is possible. This is unlikely to be the most common cause of transmission. And I can briefly go through the different modes of aerosol transmission. So the first one and the most common is going to be close contact transmission, or I should say transmission at close range. So if I am emitting aerosols, or again, if you think about smoking, it's the people closest to me that are most likely to be infected, that are most likely to inhale those infectious aerosols. The second type of transmission is what we refer to as sort of shared room air transmission. So this is really the basis for our super spreader events. And again, if you imagine sort of a bigger room with lots of people in it, but several people may be smoking in that room and there may be poor ventilation, then someone far away at the other end of the room may still end up inhaling those aerosols or that secondhand smoke. It's still going to be more concentrated closer to the source. So the people close by are still more likely to be infected, but people far away can be infected as well. And we saw that with the super spreader events like the choir in Washington State, for example. And then the third type of transmission, which is the one that you just referred to, is that sort of longer range transmission when someone's not even in the room. This is harder to prove and certainly occurs much less frequently. But depending on airflow, it is possible. This is the kind of thing that traditionally we thought of as more synonymous with airborne transmission. But what we've learned over the last almost 2 years now is that airborne transmission really encompasses all those different types of transmission.
And I presume the Omicron variant spreads more easily through aerosol than its predecessor variants. Is that right?
I don't think we know for sure yet. We do know that it's more contagious. I mean, we're seeing it spreading like wildfire through our communities. We think at this point that that's certainly partly based on its immune evasiveness. And also it's likely inherently just more contagious. We don't know if it transmits more by aerosols than the other variants. What we do know is that all of the variants have been airborne. It just seems to be more obvious to everybody with Omicron.
Okay, let me share with you and our viewers and those listening on podcast as well. This was a tweet from the World Health Organization in March of 2020, and it said, fact, COVID-19 is not airborne. The coronavirus is mainly transmitted through droplets generated when an infected person coughs, sneezes, or speaks. And then it goes on to say what you should do to protect yourself. Now, admittedly, that tweet came in the first month of COVID-19 when presumably authorities didn't know as much as they know today, but it does raise the question of why it may have taken so long to accept the notion that COVID-19 was airborne as opposed to droplet.
Yes, it's a very interesting question, and there are definitely a lot of theories on that. When we think back to July 2020, we might recall that there was a letter signed by over 200 aerosol scientists, really directed to the WHO, asking that presenting the evidence in favor of airborne transmission and really requesting that the WHO revise its guidelines. And it's taken a long time, and we have seen a shift now in the last few months with the majority of all the public health organizations now acknowledging aerosol or airborne transmission. I think there are three main reasons that it's taken so long. So the first one is rooted in history. So traditionally, since the early 1900s, we have equated transmission that occurs in close range with droplet transmission. And we do know that transmission occurs more often in close range. This sort of became some people refer to it as dogma, but it really became the dominant model of respiratory transmission for many, many years. And even airborne diseases, well-established airborne diseases like tuberculosis and measles were once thought to be transmitted by droplets. So there's a historical basis for that. And there's, a difficulty, I think, in upending the status quo. Medicine requires we want a lot of evidence, we want a lot of data, and in a fast-moving pandemic, sometimes it's hard to gather all that. And we also, I think, over the last 18 months, maybe, or at least initially, weren't necessarily having the dialogue that we should have been having with the aerosol scientists and the engineers. So it was much harder to sort of gather the evidence that we needed. And then the second reason would be a supply question. So I really do think that at the onset of the pandemic, we certainly had issues with supply of respirators or N95s for healthcare workers. We didn't, and we still don't have enough isolation rooms in hospitals. So I think supply dictated some of our reluctance as well to acknowledge airborne transmission. And then finally, I think we need to be honest that it's much harder, or it can be seen as much harder, to control an airborne transmitted disease. The onus is really on governments and on businesses to provide safe indoor air for the public and for employees. It's a lot easier to just tell individuals to wash their hands and stay 2 meters apart.
Having said that, if public health organizations had accepted the notion of airborne sooner, how might things have been different over the past 20 months?
Yeah, I think that we would have had the time to invest in the technologies that actually work to mitigate airborne transmission. And these are high quality masks, both for healthcare workers and really for the general public. Ventilation, and that includes filtration as well, so HEPA filtration units, and even something like UVGI, which is this ultraviolet germicidal irradiation, which is underutilized but has been used for years to manage TB, and it's been shown to be quite effective. So I think once we accept the science, we actually know what the tools are that work to mitigate airborne transmission, but they do require both acknowledging airborne transmission and then investing in these technologies. And unfortunately, our reluctance to acknowledge airborne transmission meant that we've had a significant delay in really going forward with these technologies.
If we accept airborne transmission, does that mean the 2 meter distancing rule that we've been told to keep between us and the next closest person to us, does that mean that rule's pointless?
No, it's certainly not pointless. And again, this is where the cigarette smoke analogy is useful. If you're standing close to a smoker, you're going to inhale a lot more of that smoke or a lot more of those aerosols than if you're standing further away. So distance is still important, but it's not enough.
The plexiglas that literally thousands of Ontario businesses have been using to separate clients from their workers or other clients from each other, are those completely useless as well?
So again, I wouldn't say they're completely useless. I think for droplet transmission, and at this point, we know there's aerosol transmission. We suspect there's droplet transmission as well. So they will be useful for preventing droplet transmission. The problem is that I think that we have relied on them at the expense of investing in better mitigation tools such as improved ventilation. And there is some evidence from aerosol science as well that aerosols can unfortunately build up sort of in that space behind the plexiglass. So they can give us false reassurance, and in some cases, they may actually, unfortunately, increase aerosol transmission.
Okay, in which case, last question here. What else, you mentioned ventilation, what else needs to be done at this stage of the game to protect people more from the aerosol as opposed to droplet transmission?
Yeah, so I think the first thing that we need to do, which is actually free, is to disseminate this information in a very clear way to the public. I think that most people want to take the right steps to protect themselves and their families. And if we can have a shared mental model, and that mental model of airborne transmission, then I think that, there's a lot of things that individuals can still do and make safer choices. But I do think we need to take the onus off individuals as well and talk about what the government and what businesses need to be doing to protect us better. So we need a more robust supply of good masks. These are respirators or N95s. These provide better protection for the person wearing the mask, as well as source control. So you have fewer aerosols leaking out from the mask, and so you're protecting the people around you as well. We have Canadian-made respirators now. We need to scale this up, and we need to distribute these and explain to people how to wear them and when to wear them. The second, as you mentioned, technology is ventilation. And, optimizing or ventilation is not something that we can do overnight. We squandered a lot of time. There's still improvements that can be made. But we have to recognize the fact that this is certainly more challenging and more resource intensive. We can, however, improve ventilation through filtration. And you've probably heard a lot of talk recently about portable HEPA units or air purifiers. Ontario's put these into a lot of schools. And these are really useful. What they do is they filter out the aerosols in the air. So they're quite effective. They need to be sized to the space. So putting a small one in a large gym is, might help a little bit, but it's certainly not going to be enough. But that's another tool that we can use. And then finally, as I mentioned before, there's UVGI, which is underutilized and which, again, can't be rolled out overnight, but which is something that I hope that we can be looking into more and investing in more. This is, unfortunately, might not be the last variant and probably not the last airborne pandemic.
Oh, dear. That's Dr. Sarah Adelman joining us from the nation's capital with some encouraging news and some not so encouraging news. Thanks, Dr. Adelman. Good to have you with us on TVO tonight.
Thank you so much.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.